Hey. We're talking about muscles today. Here we go with musculoskeletal assessment. So, here are our learning objectives for this lecture. And before we learn how to assess the musculoskeletal system, let's review the basic structures we're assessing. So the musculoskeletal system is made up of bones, muscles, joints, tendons, ligaments, and connective tissues, and they all work together to support movement and maintain our posture. Starting with bones, the adult human skeleton contains about 206 bones. And bones provide the framework of the body. They protect vital organs, they store minerals such as calcium and phosphorus, and they house bone marrow where blood cells are produced. So bones can be categorized by their structure. We have compact bones, which are dense and strong, and then we have cancellous or spongy bone, which is lighter and contains marrow spaces. And bones are also classified by shape, including long bones, short bones, flat bones, and irregular bones. So as nurses, understanding these structures is going to help us recognize how fractures, osteoporosis, and other musculoskeletal conditions can affect function and mobility. Now let's talk about muscles. So the body contains over 600 muscles, which are responsible for movement, posture, and heat production. And there are three types of muscle tissue: skeletal muscle, which is attached to bones, and it allows voluntary movement. Then we have cardiac muscle, which makes up the heart, smooth muscle, which is found in organs such as intestines and blood vessels. And so our primary focus is going to be skeletal muscle because it directly affects mobility, strength, balance, and activities of daily living. And again, those skeletal muscles attach to bones through tendons. And when muscles contract, they pull on bones to create movement at joints. This relationship between bones, muscles, and joints is what we'll evaluate during our musculoskeletal assessment. And again, we're not just assessing anatomy, we're assessing the function. So we're asking questions that may include, can the patient move normally? Do they have pain? Is strength equal bilaterally? Are there any limitations in their range of motion? Can they safely perform activities of daily living? And so all of these functional findings tell us more about the patient's health status than their actual anatomy alone. So joints are the structures that connect those bones together and allow movement throughout the body. So when we perform a musculoskeletal assessment, much of what we assess, such as range of motion, gait, and mobility, is directly related to joint function. So joints provide both mobility and stability, and some joints are designed for a large range of motion, while others are built more for protection and support. So there's three main types of joints. We have fibrous joints, also called synarthrotic joints. These are essentially immovable. An example would be the structure or the sutures of the skull. And then we have cartilaginous joints, which allow slight movement. An example would be the vertebrae of the spine. And then we have synovial joints, which are freely movable joints. These are the joints we most commonly assess in nursing because they're responsible for most body movement. Makes sense. Synovial joints contain synovial fluid, which lubricates the joint and helps reduce friction during movement. So conditions such as arthritis that can affect this lubrication and lead to pain, swelling, and decreased mobility. The slide also lists the major joints we will assess during a focused musculoskeletal exam. We have the temporomandibular joint, or TMJ. This is assessed by observing jaw movement and checking for clicking, tenderness, or pain. The shoulders, these are evaluated for symmetry, strength, and range of motion. So shoulder injuries are common because this joint has a very wide range of motion, but less stability. And for the elbows, wrists, and hands, we assess movement, strength with a grip, swelling, deformities, and fine motor function. This is especially important for conditions like arthritis or nerve impairment. The hips, knees, ankles, and feet, these are critical for mobility and gait, and we assess alignment, weight-bearing ability, balance, and range of motion. Pain or weakness in these joints can significantly increase fall risk. And finally, the spine, which provides support and flexibility while protecting the spinal cord. And during our assessment, we look for posture, spinal curvature, alignment, and limitations in movement. These are common terms you will use throughout musculoskeletal assessment to describe joint movement and range of motion. It can look pretty overwhelming at first at these terms, but once you connect them to actual movement, they become much easier to remember. So when assessing joints, we compare movements bilaterally and we determine whether the patient can move smoothly, fully, and without pain. So let's go through each term. Flexion means bending a joint and decreasing the angle between body parts. For example, bending the elbow or bending the knee. So at the ankle, we use more specific terms like dorsiflexion, which means bringing the toes upward toward the shin, and plantar flexion, which means pointing the toes downward, like pressing on a gas pedal. Then we have extension. This is the opposite of flexion. It means straightening a joint and increasing the angle between body parts. Abduction means moving a limb away from the midline of the body, so being abducted away from aliens taking you away. So moving the limb away from the midline of the body. Adduction means moving the limb back towards the midline. Rotation refers to turning a body part around its axis, for example, turning the head side to side, or internally and externally rotating the hip. Circumduction, this is a circular movement that combines flexion, extension, abduction, and adduction. And the shoulder is a good example of a joint capable of circumduction, where we can move our joint in an entire circle. Inversion and eversion, these are movements of the foot. So inversion means turning the sole of the foot inward. Eversion means turning the sole outward. So these movement terms are important because they help us accurately document findings and identify limitations in mobility. And if a patient can't perform a movement fully, or if pain occurs during movement, they can indicate injury, inflammation, nerve impairment, or musculoskeletal disease. And as they are moving, we are looking at symmetrical movement. Is there weakness? Is there pain, guarding, or stiffness? Is the movement itself smooth? These are observations that are going to help us determine functional status and also patient safety risks. Back to older adults. So when assessing older adults, it's important to recognize the normal age-related musculoskeletal changes that occur over time, because these changes can affect mobility, balance, strength, independence, and their overall safety. So one major change is decreased bone density. So as people age, bones gradually lose calcium and become more porous and fragile. So this increases the risk for fractures, especially in conditions like osteoporosis. Even minor falls can lead to serious injuries such as hip fractures. You may also notice increased bony prominences. This occurs because of both decreased muscle mass and changes in subcutaneous tissue. So bones may appear more visible or prominent, especially over areas like the clavicles, spine, knees, and hands. And another common change is cartilage degeneration. And over time, the cartilage that cushions our joints wears down, and it leads to stiffness, pain, crepitus, and decreased range of motion. And this is commonly seen in patients who have osteoarthritis. Older adults, they also experience joint stiffness and lax ligaments. So ligaments lose elasticity with age while joints become less flexible. So patients may report stiffness, especially in the morning or after periods of inactivity. You'll also commonly see muscle atrophy, which is the loss of muscle mass and strength. And this can contribute to weakness, slower movement, decreased endurance, and increased fall risk. So these changes are clinically important because they're going to directly affect our patients' mobility, their ability to perform activities of daily living, balance and gait, risk for falls and injury, and their overall functional independence. So during our assessment, we want to determine whether findings are expected, age-related changes, or signs that require further evaluation. So back to cultural variations and health disparities. So this slide reminds us that musculoskeletal health is influenced by much more than anatomy. So cultural background, environment, occupation, socioeconomic factors, nutrition, and biologic differences can all affect musculoskeletal development and disease risk. So first, bone mineral density. This can vary among individuals and populations during genetics, nutrition, physical activity, hormone levels, and access to care. When you have low bone density, it increases the risk for osteoporosis and fractures. So keeping that in mind. Also, the curvature of long bones can vary depending on nutritional status and childhood development. For example, vitamin D deficiency during growth can contribute to abnormal bone development during, sometimes we see things like bowing of the legs. Which connects us to the next point, which is conversion of active metabolites by sunlight. So sunlight exposure helps the body synthesize vitamin D, which is essential for calcium absorption and bone health. Hopefully we all know. And then individuals with darker skin pigment may require longer sun exposure to produce adequate vitamin D because increase in melanin reduces vitamin D synthesis. So this is important clinically because vitamin D deficiency can contribute to osteomalacia, osteoporosis, muscle weakness, and increased fracture risk. The slide also mentions biologic sex and hormone exposure. Hormones such as estrogen and testosterone play important roles in bone density and muscle mass. For example, estrogen helps maintain bone density, and after menopause, declining estrogen levels increase women's risk for osteoporosis, whereas testosterone can contribute to muscle mass and bone strength. So considering the impact of that, along with working conditions and lifestyle factors like repetitive movements or heavy lifting, poor ergonomics, prolonged standing, or a sedentary lifestyle, these can all contribute to musculoskeletal strain and injury. So repetitive wrist motion may contribute to carpal tunnel syndrome or being on your phone too long. You know, I'm noticing holding my phone up is really doing a number on my wrists recently. So it's a reminder to put it down. Anyway, poor posture and ergonomics may contribute to chronic back pain. Lack of movement can lead to muscle weakness and decreased joint flexibility. So keeping that in mind. So this slide focuses on the priorities of a musculoskeletal assessment. So our goal isn't simply to identify abnormalities. We want to determine what requires immediate attention and how musculoskeletal findings impact patient safety and function. So the first focus is identifying the specific problem. We want to determine what symptoms the patient is experiencing, when it started, whether it affects movement, strength, or daily activities, whether the issue is acute or chronic. For example, sudden severe joint pain after a fall. This is very different from chronic stiffness that develop gradually over years. Another priority is going to be alleviating pain. Musculoskeletal pain can significantly limit mobility and quality of life. So pain may also prevent patients from participating fully in assessments or rehabilitation activities. So we're assessing location of pain, severity, quality, triggers or relieving factors, impact on mobility and function. We also focus on preventing complications. So limited mobility can quickly lead to complications like falls, pressure injuries, muscle deconditioning, contractures, blood clots, loss of independence, pneumonia from atelectasis. So next, we're going to inspect proper alignment of the limbs, joints, and spine. And normal alignment helps maintain balance, posture, and efficient movement. So during inspection, we're looking for deformities, swelling, unequal limb positioning, curvature of the spine, any contractures. Also guarding behaviors. We also observe for symmetry of size, shape, position, and movement of the extremities. So we're comparing one side of the body to the other. Some musculoskeletal findings that require urgent intervention would be suspected fractures, neurovascular compromise, severe pain, loss of circulation, inability to bear weight, and acute spinal injury. These are situations where safety and stabilization come before completing a full assessment. So this slide focuses on the nursing priorities and screening tools we use during a musculoskeletal assessment. So when a patient presents with a musculoskeletal injury or complaint, one of our first priorities is assessing overall stability and circulation. So this includes obtaining their vital signs because blood loss, pain, or systemic complications can affect heart rate, blood pressure, respiratory rate, and oxygenation. So we also are monitoring pulses distal to the injury. So distal means below the site of injury. For example, if a patient has a fractured wrist, we're going to assess radial pulses and circulation in the hands and fingers. So in addition to pulses, we also assess color, temperature, capillary refill distal to the injury. And these assessments are going to help us determine whether blood flow and perfusion are still intact. If we see things like pale or cool extremities, delayed cap refill, weak or absent pulses, this could indicate impaired circulation or neurovascular compromise, which is going to require immediate attention. So hopefully you're, letting your provider know. We also assess for sensation, movement, increasing pain, swelling, especially after fractures, casts, or orthopedic surgery. And the second part of the slide introduces the GALS locomotor screen. GALS stands for Gait, Arms, Legs, Spine. This is a quick screening assessment used to identify musculoskeletal abnormalities and determine whether a more focused assessment is needed. So first we observe gait. Is the patient walking steadily? Are movements smooth and coordinated? Is there any limping, shuffling, guarding, or imbalance? Then we assess the arms by observing range of motion, symmetry, and strength. Next are the legs, where we look at mobility, alignment, joint movement, and weight-bearing ability. And finally, we assess the spine, so observing posture, alignment, spinal curvature, and range of motion. So the GALS screening is especially useful because it provides a rapid overview of musculoskeletal function while also helping to identify fall risk, weakness, pain, or mobility limitations. So this slide is going to focus on collecting subjective data during our musculoskeletal assessment. So this includes the information the patient tells us about their symptoms, their health history, and risk factors. So one major area to assess is the patient's past medical history. We want to ask about previous fractures or injuries, arthritis, osteoporosis, chronic pain conditions, neuromuscular disorders, falls, surgeries, or joint replacements. Past injuries can affect current mobility and function even years later. We also want to assess lifestyle and personal habits because these greatly influence musculoskeletal health. So questions may include what types of work do you do? Do you exercise regularly? Do they participate in repetitive activities or heavy lifting? What is their activity level? Have they ever experienced a fall or have they had a recent fall? What's their diet like? Because lifestyle factors such as inactivity, smoking, poor nutrition, or repetitive strain can contribute to musculoskeletal problems. And next, we're reviewing the patient's medications. So certain medications can affect bones, muscles, or joints. Things like long-term corticosteroid use can increase osteoporosis risk. Statins may cause muscle pain or weakness. Anticoagulants increase bleeding risk after injury. Some medications can contribute to dizziness and falls. I'm sure you've learned from the antihypertensive medications. So we're always considering whether medications could be contributing to the patient's symptoms. And finally, we're assessing family history. Some musculoskeletal conditions have genetic components. This includes osteoporosis, rheumatoid arthritis, osteoarthritis, and certain connective tissue disorders. So family history can help us identify patients at an increased risk for future disease. It's also important to explore the patient's current symptoms, like any common questions would be, do you have pain? Where is it located? What makes it better or worse? Have you noticed weakness or stiffness? Have you had any difficulty walking or performing daily activities? And remember, we're, collecting facts, and it's helping us to understand how musculoskeletal issues affect the patient's daily life, their mobility, independence, and safety. So, teaching and health promotion related to musculoskeletal health. One important goal is reducing fall-related deaths among older adults. Falls are one of the leading causes of injury and loss of independence in older adults. So when assessing fall risk, we consider muscle strength, balance, mobility, vision, medications, environmental hazards like throw rugs, which older adults really love. I'm not sure why. History of previous falls. Even one fall can significantly affect an older adult's confidence and independence. Another focus is increasing screening for osteoporosis because it often develops silently until a fracture occurs. So early screening helps identify patients at risk before major injury happens. And our patients at higher risk include older adults, postmenopausal women, patients on long-term corticosteroids, and individuals with low calcium or vitamin D intake. Also, patients with low physical activity levels, like a sedentary lifestyle. Related to this is the goal of reducing hip fractures among older adults. Hip fractures can lead to major complications like loss of mobility, long-term rehabilitation, increased dependence on others, increased mortality risk. Preventing falls and maintaining bone health are essential nursing priorities. So we're emphasizing increasing physical activity, regular movement, maintaining muscle strength, improving balance, preserving joint flexibility, increasing bone density, and reducing fall risk. You'll also see the short musculoskeletal function assessment, which is a tool used to evaluate how musculoskeletal conditions affect daily functioning and quality of life. Functional assessments are important because patients may appear physically stable, but they still struggle with activities like walking, climbing stairs, dressing, bathing, or carrying objects. So this slide also references bone density testing, which is commonly done using DEXA scans to evaluate osteoporosis risk. And I feel like everyone is normally screened maybe around their 50s, 60s with a DEXA scan to evaluate this risk. Finally, scoliosis screening. This is used to identify abnormal spinal curvature, especially during adolescence. I remember getting this screening when I was in grade school, so because that is when rapid growth occurs. So they'll do that screening then. As nurses, we're teaching and preventing our assessment. Our education may include fall prevention strategies, safe exercise, proper footwear, nutrition with calcium and vitamin D, smoking cessation, and home safety modifications. So the overall goal here is helping patients maintain mobility, independence, and quality of life across the lifespan. This slide reviews some of the most common symptoms that patients are going to report during a musculoskeletal assessment, and these are going to help guide our focused assessment and clinical judgment. So the first most common symptom is pain or discomfort. So pain involving muscles is called myalgia, while pain involving joints is called arthralgia. So when we're assessing pain, we want to explore the location, severity, timing, quality, triggers, what relieves it, how it affects function. Another common symptom is weakness. Patients may describe weakness as difficulty lifting objects, trouble climbing stairs, fatigue and walking, feeling unstable. So we want to determine whether weakness is generalized or is it isolated to one area, and whether it affects safety or mobility. Next is stiffness or limited mobility, and this can occur from pain, inflammation, injury, or long-term immobility. The slide also mentions contractures, which are permanent tightening or shortening of muscles, tendons, or joints that limit movement. So contractures are often seen in patients with prolonged immobility, sometimes neurologic disorders or chronic conditions. We also assess for deformity. So deformities may result from arthritis, fractures, congenital conditions, chronic joint disease. An example of this would be spinal curvature changes, joint enlargement, or abnormal alignment. Another major symptom is lack of balance and coordination, also called ataxia. Patients with ataxia may have unsteady gait, difficulty coordinating movements, increased fall risk, and this can result from musculoskeletal problems, but also potentially neurologic conditions, even weakness or just inner ear disorders. And the slide also reminds us about older adults, again, who commonly experience things like decreased muscle mass, reduced flexibility, slower movement, balance changes. And we need to, again, differentiate normal aging from abnormal findings. And finally, we're just, again, considering cultural considerations. Patients may express pain differently depending on their background, beliefs, or past experiences with healthcare. Some patients may openly describe pain while others may minimize symptoms. Cultural and occupational factors can also affect musculoskeletal health through activity level, repetitive movements, access to care, nutrition, exercise habits. So combining subjective symptoms with objective findings to determine how musculoskeletal issues are affecting function, safety, and quality of life. Now we're getting into the objective portion of the musculoskeletal assessment, including the equipment needed and how to properly prepare both the environment and the patient. So first, let's talk about equipment. A goniometer. This is a tool used to measure joint angles and range of motion. While you may not use one during every routine nursing assessment, it can be useful in rehabilitation settings, orthopedic care, or when monitoring progress over time. I've seen a lot of physical therapists use this tool. Also a tape measure. This may also be useful to compare muscle size, swelling, edema, or limb circumference bilaterally. So things like measuring calf circumference can help monitor for asymmetry or muscle atrophy. Preparation is also an important part of the assessment. So before beginning, we want to assemble all of our supplies so the assessment can flow smoothly and safely. The environment should be warm and private. Patients may need to remove clothes or move through different positions, so maintaining comfort and dignity is important. Always performing hand hygiene before and after. You may need to assist the patient into a gown and provide proper draping to maintain privacy while still allowing visualization of the areas being assessed. It's also important to explain the process to the patient before beginning, so patients are often more relaxed and cooperative when they understand what you're assessing and why. Patients may need to also walk or change positions, lift extremities, bend joints, perform resistance movements, so safety is always a priority. Especially patients who are experiencing pain, weakness, balance, or have that fall risk. This slide outlines the components of our initial survey, musculoskeletal survey. So the first thing we need to assess is posture. We look at how the patient naturally holds themselves while sitting, standing, and walking. Normal posture should appear upright, aligned, and balanced. Abnormal findings may include a stooped posture, uneven shoulders or hips, spinal curvature, guarding due to pain. Posture can provide clues about pain, weakness, spinal disorders, or neurologic impairment. So we're looking closely at that. Next, we observe gait and mobility, and we want to watch how the patient walks. Is the gait smooth and coordinated? Are their movements steady? Is the patient favoring one side? Do they need assisted devices? Any abnormal gait patterns such as limping, shuffling, or unsteadiness, it can indicate things like pain, weakness, neurologic issues, or balance problems. On to balance. So balance is crucial for safety and fall prevention. So patients with impaired balance, they may sway when they're standing upright. They may require support or appear unstable when standing or walking. So closely related to this is coordination. So coordination involves smooth, purposeful movement. And so things like difficulty coordinating movements may suggest musculoskeletal, neurologic, or vestibular problems with the ears. Next, we perform inspection and palpation of the extremities. So during inspection, we assess for symmetry, swelling, redness, deformities, muscle size, alignment. And then during palpation, we assess for tenderness, warmth, crepitus, edema, and muscle tone. And we're assessing each joint in the spine with our inspection and palpation. We're also looking at range of motion, muscle strength. And muscle strength is commonly graded on a 0 to 5 scale, with 5 being full strength against resistance. And finally, we assess fall risk. The slide mentions tools such as the Morse Fall Scale and Hendrick 2 fall risk model, and these are just tools that help identify patients at increased risk for falls based on factors like mobility limitations, mental status, medications, history of falls, gait abnormalities. Fall prevention is a major nursing responsibility because, again, musculoskeletal impairment directly affects patient safety and independence. So with the fall risk, in clinical, you might have seen what scale they utilize for fall risk. If not, I would advise you to, next time you go, ask your clinical instructor to show you how they calculate the fall risk. So this slide, I know I mentioned muscle strength a little bit, but this slide really outlines the standard grading scale used to assess muscle strength during our musculoskeletal exam. So again, muscle strength is typically graded on a 0 to 5 scale, with 5 being normal strength and 0 indicating no muscle activity. So when we're testing strength, we usually compare both sides of the body and we assess the patient's ability to move against gravity and resistance. And so through this slide, it kind of talks you through how you would grade muscle strength depending on your patient's ability. And let's just finally go through some of the specific lab and diagnostic tests commonly associated with musculoskeletal disorders and what they can tell us clinically. So LDH, this is lactate dehydrogenase. And LDH is an enzyme found in many tissues throughout the body, including muscle tissue. So when cells are damaged, LDH can be released into the bloodstream and elevated. So you might see that elevated with muscle injury, tissue breakdown, trauma, certain inflammatory conditions like sepsis. LDH is nonspecific, meaning it can increase for many reasons. So usually we need to interpret these findings along with other things like clinical manifestations. CK, this is creatine kinase. This is one of the most important labs related to muscle injury. So CK rises when muscle cells are damaged, and elevated CK may occur with muscle trauma, rhabdomyolysis, which is rapid muscle breakdown, myositis, intense exercise, like if you go to spin class, certain medications such as statins, and very high CK levels can be dangerous because muscle breakdown products can damage those kidneys. The kidneys cannot filter that muscle breakdown out fast enough, and they can actually get injured. Especially patients who have rhabdomyolysis, they might present with clinical manifestations such as severe muscle pain, weakness, dark urine, and again, those elevated CK levels. So that's important priority, and especially the risk for acute kidney injury. ALT and AST, these are liver enzymes, but they can also increase with muscle injury because these enzymes exist in muscle tissues too. So seeing elevated AST and ALT may occur with muscle trauma, muscle inflammation, that rhabdomyolysis, And this is why providers look at the whole clinical picture rather than assuming abnormal AST and ALT always indicate liver disease. Alkaline phosphatase, or ALP, this is associated with bone activity and liver function. So in musculoskeletal conditions, elevated ALP may suggest increased bone turnover, bone healing after fractures, bone disorders such as Paget disease, and bone cancer. A note, though, children and adolescents may naturally have higher ALP levels because they are growing. Uric acid. Uric acid is most commonly associated with gout. So when uric acid accumulates, crystals can form in joints and cause intense inflammation. Classic findings with gout include sudden severe joint pain, redness, swelling. It's often affected the big toe because it's a cooler area and uric acid loves to build up in cooler areas of our body. But elevated uric acid supports the diagnosis of gout, although patients can sometimes have gout symptoms even with normal levels during an acute attack. ESR, erythrocyte sedimentation rate. This is a nonspecific inflammatory marker. And when inflammation is present, red blood cells settle faster in a test tube. That increases the ESR. So elevated ESR may occur with rheumatoid arthritis, infection, autoimmune disorders, inflammatory conditions. And because ESR is nonspecific, it doesn't tell us exactly what's causing the inflammation, only that inflammation is occurring. Also, C-reactive protein, CRP, this is another inflammatory marker. It does rise quicker than ESR, and it's often used to monitor acute inflammation, infection, autoimmune flare-ups, response to treatment. But again, this is a nonspecific inflammatory marker. Rheumatoid factor, or RF, this is an antibody often associated with rheumatoid arthritis. So a positive RF may support the diagnosis of RA, especially when it's combined with symptoms such as symmetrical joint pain, morning stiffness, swelling of small joints. But some patients with rheumatoid arthritis may have negative RF, and some healthy individuals may also test positive for RF. So again, it can be nonspecific. Diagnostics like x-rays, we know these are commonly used to assess fractures, joint alignment, degenerative changes, osteoarthritis, or bone deformities. These are excellent for evaluating bone structures. And then MRI, this is a more detailed image of soft tissues, especially useful for ligaments, tendons, menisci, however you say it, discs, spinal cord, and muscle injuries. Again, we talked about this a little bit, but DEXA scan, a bone density scan to look at osteoporosis or osteopenia, especially in older adults, postmenopausal women. And the next step is going to be prioritizing your hypothesis, right, and taking action. So using our assessment findings to determine what's most urgent, what could be causing the symptoms, what interventions are needed immediately. And then musculoskeletal conditions can change over time. So we always are reassessing or monitoring for increasing pain, changes in circulation, swelling, mobility decline, neurovascular changes, and any improvement they've had after our interventions. And then always good documentation, which helps communicate patient status clearly and support continuity of care. Interprofessional collaboration, maybe we're working with occupational therapy, physical therapy, orthopedics, rehab specialists, or case management to help improve our patients' outcomes. And then coming up with a plan of care based on our patient's specific needs. Maybe that's pain management, maybe fall prevention, or exercise programs, assistive devices. And then finally, we're evaluating our outcomes. Did the pain improve? Is mobility better? Has strength increased? So clinical decision making is really about connecting our assessment findings to coming up with a safe, individualized plan of care for our patient. And that's it. That was great. I hope you have a good day. I can't wait to work with you for our musculoskeletal focused assessment. Yeah. See you later.